Good afternoon, everyone. We all know that sleeve gastrectomy is one of the most popular bariatric procedures which is being performed all across the world. And one of the most major concerns after a sleeve has been that of acid reflux. And there have been multiple studies with conflicting results, where some studies have actually shown that acid reflux increases after sleeve gastrectomy. And there are also studies that have said that the acid reflux actually goes down. And today we will discuss a very, very important study by Professor Iannelli's group. And we have with us Dr. Lionel Sebastianelli and Dr. Frey Sebastian. They are associated with the Department of Digestive Surgery and Liver Transplantation at the University Hospital of Nice in France. And the title of the study is Systematic Endoscopy 5 years after sleeve gastrectomy results in a high rate of Barrett's esophagus, and results of a multi-center study. And before we start the presentation by Dr. Sebastianelli, I would request Manula to start a poll. We have just 2 questions. I think if the audience can take that poll, it will give us some idea about what people are thinking across the world. So the poll is open now, and I request the attendees to select the preferred option. This will remain open for 5 more seconds. I think we can close the poll now. And okay, so almost everyone has said that 79% of people think that upper GI endoscopy should be a mandatory preoperative investigation before sleeve gastrectomy, and there are still 20% who feel that it should not be done. So I request Dr. Lionel to please go ahead with his presentation.
Hello, everyone.
Hello.
I hope you can hear us well, and we're happy to present our study to you all. And thank you. We would like to thank first the Ifso to give us such an opportunity to present our work. So normally you should be able to see the PDF in full screen. To start, and you all probably are aware of those numbers already, but there's currently what we call an obesity epidemic with more than 650 million of obese persons in the world. This concerns all the countries of the world. And on the same slope, bariatric surgery has been growing, and more surgeons specialized in bariatric surgery everywhere. Now, in this graph is just to illustrate how much bariatric surgery has grown, and especially sleeve gastrectomy, as it currently is the most performed surgery, representing almost half of all the bariatric surgeries. Now, an important issue of obesity is that it increases the risk of gastroesophageal reflux disease. Nowadays, it concerns more than 50% in some series of obese persons, and it is mainly due to the increase of intra-abdominal pressure. A sleeve gastrectomy, which consists in removing 1/3 of the stomach, can as well as improve the symptoms of GERD or worsen them. It is now accepted in the literature that GERD can be a long-term complication of sleeve gastrectomy. The explanations for it are numerous. It can disrupt the anatomical anti-reflux mechanism. It can decrease the gastric compliance or increase the intragastric pressure, or it can induce a localized strictures or the angulation of the gastric tube, etc., especially also depending on the technique of surgery. One of the consequence of GERD is the metaplastic change due to the chronic acid exposure. This is what we call the Barrett esophagus, and the natural evolution, as we know, is the adenocarcinoma. It is diagnosed thanks to endoscopy with biopsy. This is just a few pictures to show you the two different types of mucosa when we have a Barrett esophagus, but you are all probably already aware of this. Now, the Barrett esophagus is classified using two main parameters: the height of circumferential metaplasia from the esogastric junction and the maximum height of metaplasia. Now, concerning the association of sleeve gastrectomy and Barrett esophagus, only a few data are found in the literature. One important information is that there is a clinical discordance with almost 26% of patients with Barrett esophagus, but asymptomatic. Knowing all that, we wanted to measure the prevalence of Barrett esophagus at least 5 years after sleeve gastrectomy in an heterogeneous pool of patients. We gathered prospectively data from 5 different centers in France and in Italy. Our secondary goals were to measure the prevalence of GERD symptoms, of endoscopic signs of esophagitis, and also the use of PPI. We also tried to identify any risk factors associated with Barrett esophagus. The study was conducted in January 2017 to July 2018, and all centers needed to include at least 10 patients. The inclusion criteria were simple: preoperatory upper GI endoscopic with no Barrett esophagus diagnosed, a follow-up consult at 5 years or more, a secondary upper GI endoscopy at 5 years or more, and obviously the patient's consent. These are the exclusion criteria. Each investigators of each center needed to fill out the database with standardized data, thus collecting all the characteristics of each patient, such as BMI, symptoms of GERD, use of PPI, etc., etc. The evaluation of the outcome was the pathology definition and the macroscopic observation of Barrett esophagus only was not enough. The total weight loss and the excess weight loss were calculated using standard formulas, and the failure of excess weight loss was defined by an excess weight loss of less than 50%. Finally, the definition of GERD was clinical, with presence of pyrosis, regurgitation, and use of PPI. We included a total of 90% patients with a mean age of 41 years old, a mean pre-op BMI of 46, a mean total weight loss of 25%, and a mean excess weight loss of 58%. So concerning the patient's characteristic before sleeve gastrectomy and at 5 years, there was an expected significant difference of weight and BMI. Now, concerning our principal outcome, the rate of Barrett esophagus was up to 18.8% with up to 17 patients. However, no dysplasia was diagnosed in our study. Concerning the secondary outcomes, there was an increase of all the criteria at the follow-up, with symptomatic GERD going from 22% to 68%, and a similar increase in use of PPI. We then analyzed the different centers, and the only difference we noticed concerned the rate of GERD in pre-op in one center. Now, this can be explained by the fact that some centers try to avoid to offer sleeve gastrectomy to patients with symptomatic GERD. At follow-up, the same comparison between centers showed only a variation of esophagitis, and our main outcome was similar between all centers. Also, symptomatic GERD was present in more than 67 to 92% of patients. as you can see on the tab. In addition, we compare patients with bariatric esophagus versus no bariatric esophagus. We found out that 94% of patients with bariatric esophagus had symptomatic GERD, but the difference was non-statistical. However, more interestingly, patients with bariatric esophagus had more often a failure of their sleeve gastrectomy with an excess weight loss inferior to 50%. This correlation between failure of sleeve gastrectomy and presence of bariatric esophagus was confirmed in a multivariate study with an odds ratio of 6.7, as you can see. No other correlation were found. Now, we then focused on the evolution of GERD. As said before, there was a significant increase in the prevalence of symptomatic GERD, going from 21 to 76%. Out of the 68 patients concerned, 48 had a GERD de novo, whereas the 20 others were the symptomatic ones before sleeve gastrectomy. The latter had an improvement of their symptoms in 3 cases, a worsening of the symptoms in 8 cases, and an identical symptomatology in 9 cases. Concerning the external validity of our study, if we look at Jenko et al. In Roma, they were the first team to publish similar results, finding a rate of 17.2% of bariatric esophagus in sleeve gastrectomy patients. Falzenreich et al. In Vienna found a rate of 15%, but they had a quite low pool of patients. Now, in our study, only 6% of patients with bariatric esophagus did not have any GERD symptoms. This result is in discordance with the 2 previous studies, as they found a rate of 26.4% for the team of Jenko and a 66% of the team of Felsenreich. This difference can be due to a differential of the definition of GERD. We considered as symptomatic even patients with occasional signs or with control sign by PPI use. PPI users concerned also patients using PPI punctually and not daily. Now, the main question that our study revealed is, should we follow up all sleeve gastrectomy patients systematically with an upper GI endoscopy or just the one symptomatics? As we said in the beginning, the rate of exposition time of gastroesophageal reflux disease is directly correlated to the appearance of bariatric esophagus. Now, as sleeve gastrectomy is on the rise, we should diagnose more and more bariatric esophagus, and thus it is understandable that systematic upper GI endoscopy could be performed in the follow-up. As the natural evolution of bariatric esophagus is adenocarcinoma, the question of such complication is quite concerning. Now, however, in the literature, there's only one case report that was published. The absence of such complications so far can be explained by different hypotheses. A difference in process of degeneration, a difference in the quality of reflux, an insufficient background so far, etc. In France, the French Society of Endoscopy recommends a checkup at 2, 3, or 5 years, depending on the height of bariatric esophagus. Another alternative could be the conversion in gastric bypass, as it functions as an anti-reflux system due to the long alimentary limb. This alternative could be very interesting, especially in patients in failure of sleeve gastrectomy, so that it can complete the loss of weight and also resolves GERD symptoms and even buried esophagus. A recent study even described a regression of buried esophagus after gastric bypass. Now, our study obviously have some limits, such as pre-op data collected retrospectively, a lack of objectivity in the definition of GERD, or even limited number of patients per center. The strength, however, is the fact that it's a multicentric study that limit technical variation of sleeve gastrectomy. The upper GI endoscopy was standardized and shared between all centers, and the outcome was an histological description and wasn't just a macroscopic diagnosis. To conclude our study, buried esophagus is a long-term incidence after sleeve gastrectomy, and it is well known now, and it should be taken seriously. A systematic follow-up with endoscopy is a strategy that should be considered for those patients, and even more the young ones, as the exposition would be even longer. Now, obviously, additional study, including a higher number, should be required, and that would definitely help in establishing new guidelines. We thank you all, and we are excited to answer all your questions.
Thank you so much, Dr. Lionel. And I think do the participants have any questions for Dr. Lionel and Dr. Sebastian?
Yeah.
I don't see any questions yet, but maybe we can start with a question. And I think there was one thing which I read in the paper was a link between weight loss failure and Barrett's esophagus. Could you please elaborate on that?
Yeah, of course, no problem.
So I think it was mentioned that patients who had Barrett's esophagus had weight loss failure as well.
Okay.
Okay, so hi everybody. I'm going to try to speak English, but my English is really bad. So one hypothesis could simply be the fact that obesity is now a risk factor of Barrett's esophagus, and thus a weight loss failure post-sleeve gastrectomy would logically increase that risk. Different mechanisms can drive to it. Increased intra-abdominal pressure, decreased gastric compliance, increase the intragastric pressure too, and often a persistence of high fundus content, often a gastric twist, localized stricture with narrowing of the horizontal and vertical junction, a funnel shape, and also a hiatal hernia. This is all in addition to the fact the sleeve is most often dilated at the level of the remnant acid-secreting gastric fundus.
All right. Okay. And I think we have a question from Eric. Eric wants to know if we offer a gastric bypass after a Barrett's esophagus sleeve, what is the percentage of Barrett's esophagus remission? Is there any data on that? Is there any data on Barrett's esophagus remission after you convert the sleeve to a gastric bypass?
Okay, give me a second.
Sorry, we can't hear you.
So in our study, we converted some patients that benefited first from a sleeve gastrectomy with buried esophagus. We converted them with a gastric bypass, but so far we don't have the results yet.
Yeah, I think we don't have any reports which have been published with that topic. So there's another question by Dr. Ayad Buhabi who wants to know that what would you do for a patient post-sleeve with Barrett's esophagus and dysplastic changes?
Sorry, can you repeat?
The question is, what would you do for a patient post-sleeve who's developed Barrett's esophagus with dysplastic changes?
So, after a sleeve gastrectomy with a patient that has Barrett's esophagus,
Yes.
two main options are available. The first one is to follow them with an upper GI endoscopy,
Okay.
and make sure that it doesn't evaluate. And the second option is, as we recommend, is to do a gastric bypass, which should be even more recommended if the excess weight loss is not attained.
All right. Okay. And there is another question by Dr. Zara who wants to know on what intervals would you suggest doing upper GI endoscopy post-sleeve?
Okay.
Would you do it once in a year, once in 2 years?
Does that include patients with Barrett's esophagus, or just after the sleeve without
Just,
for every?
just after sleep without any other, just a routine follow-up endoscopy. What should be the ideal interval?
We think that it should start at 5 years, as we did not have any Barrett's esophagus before that.
And we didn't find any dysplasia. So it's just metaplasia, it's not dysplasia.
At 5 years.
At 5 years, yeah.
Okay, so you recommend that it should be started at the end of 5 years and not before that,
Maybe,
unless the patient is symptomatic.
Yeah. Yes, exactly.
Okay, and then Dr. Saber wants to know, in patients with weight loss failure after sleeve gastrectomy and no evidence of Barrett's or signs of esophagitis, would you consider doing a duodenal switch or SADI versus RYGB?
On n'a pas cette expérience dans notre centre.
So basically the question is that if the patient has done a sleeve, he does not have Barrett's esophagus, but he hasn't lost enough weight. So you want to do a revisional procedure for weight loss. And what would be the choice of procedure? Would you continue to do a DS or a SADI, or would you prefer to do an RYGB?
Du lit que dans notre centre, on ne veut pas du tout de SADI ni de bypass.
In our centers, we do not perform any SADI or any duodenal switch.
Okay.
We mainly do gastric bypass.
Okay, so at your center, you would preferably do a gastric bypass, but I think this is a choice which the doctor has to make depending on the patient, the diet of the patient, the geography where the patient stays, and what is the preferred procedure after discussing with the patient as well. So maybe either of them could be done. Right. Any other questions? I think this is the last question over here, and. I have one question. I think there was one very important point which was mentioned in your paper. There is a hypothesis that there is a difference in the rate of adenocarcinoma in normal stomach as compared to post-sleeve stomach. So could you tell us a little bit about that? What are the changes that happen in a post-sleeve stomach that may probably not lead to such a high incidence of adenocarcinoma despite having Barrett's esophagus?
For now, it's just speculations because
yes.
We have no literature on this subject.
Right.
Because that we have just few hypotheses. Maybe the gastrectomy might alter the chemical characteristic of the refluxate, blunting its carcinogenic effects on the esophageal epithelium, increasing the time interval required for the malignant transformation. And also, obesity has also been shown to be a risk factor itself for esophageal adenocarcinoma. So if patients don't achieve weight loss, may thus exert protective effects.
Right. We have another question from Dr. Raman Goyal, and he's asking you that you've selected only 10 patients from every center. So were only the symptomatic patients endoscoped, or were there patients who were asymptomatic as well?
Tu dis que dans notre série, 94% de...
In our study, we had 94% symptomatic. And if we look at the literature in the series of Janko and the other one, they also had a very high percentage of patients symptomatic. So yes, we think it should be systematic for all patients.
No. So all these patients who were scoped, majority of them were already symptomatic for reflux disease.
Oh. No, we think it should be for every single patient.
Not only the symptomatic.
Okay. And there's another question from Dr. Kamran Shah. He wants to know that did you consider...
Iannelli is there.
Sorry. Yeah. So did you consider comparing the development of Barrett's esophagus after a 5-year period within non-operated obese patients with the 5-year rate incidence of Barrett's esophagus after sleeve gastrectomy? So what he wants to know is that have you considered comparing 5-year rates of development of Barrett's esophagus in patients who were not operated? So could it be the natural progression of obesity per se?
This would be actually an interesting study, but it's not that easy to do this because of the long-term follow-up. So we said we're supposed to enroll patients at baseline in 2 different groups. So those who are supposed to undergo surgery, those who are in the control group, something like the design of the SOS study, and then look for 5-year results. There is a study which is probably going to be designed in France next year like this, but only for patients undergoing surgery. You need to build a prospective cohort. Having a prospective control cohort of patients is going to be a very complicated matter. I mean, this would be actually interesting, but very difficult to accomplish as a study. So.
Correct. And Dr. Zara wants to know, do you suggest doing upper GI endoscopy post single anastomosis gastric bypass? Do you perform that at your center?
That's a complicated issue. I personally do not do the mini bypass or omega loop bypass. The most important problem is when the biliary reflux adds to the acid reflux, and on the esophagus mucosa, this becomes kind of atomic bomb. So for these patients, I think there should be the same control at 5 years, and then obviously patients Barrett then.
Right. Okay. And Dr. Ayad wants to know that would you consider Barrett's esophagus as an absolute contraindication for sleeve gastrectomy?
In my practice, I would say yes. I mean, I say yes because we actually the only positive effect of sleeve gastrectomy on Barrett's esophagus could be the weight loss. Now, as patients most often complicate the sleeve gastrectomy with reflux, with GERD, then going with a GERD on Barrett is actually not a good idea. So I think if there is a Barrett esophagus, even metaplasia, only metaplasia, the Roux-en-Y remains the operation of choice. Then, if you have compliant patients that wants the sleeve and the patient is comes to the follow-up every year, then an endoscopic follow-up can be done, and you know, maybe it's not so. But on a if you have to give an advice on a procedural choice, this would be the Viii. That's right.
Right. And Dr. Kamran wants to know that does the time account for some of the higher rate of Barrett's after sleeve gastrectomy? If yes, it could be interesting to know. Not very clear with this question, but maybe then.
Do you mind repeating?
I'm sorry?
We did not catch the question actually exactly.
Yeah, actually, I think what he means is probably that as I mean, in the longer follow-ups, would there be chances of getting Barrett's esophagus more after sleeve gastrectomy? So as more years pass by, would there be higher incidence of developing Barrett's esophagus?
Okay. Interestingly, the second study, the one that's been done before the one we did, was done in 10 years, and we found the same rate. Now, this is not a really large cohort of patients, but still, you're around in between 15 and 20%. I personally believe that within 5 and 10 years, the rate of GERD will almost remain the same, and after 10 years, if patients they have to do a Barrett, they will do within 10 years, not longer. But who knows, finally.
Okay. And Dr. Eric wants to know that if the patient has esophagitis and hiatal hernia in the preoperative period, do you offer him a sleeve or a bypass at your center? I think that's quite obvious. You would offer a bypass.
Yes, we offer a bypass. Symptomatic esophagitis, I think there is enough literature data to go for a bypass. Again, always the same story. If some patients want the sleeve, they insist for having the sleeve. You can do this, try to treat the hiatal hernia, but most of the time, GERD symptoms remain stable or get worse.
Exactly. So maybe I can ask a question here. Your study is I mean, there are 90 patients in this study. Do you intend to plan for a bigger study with more patients, with probably patients from more countries?
That's what we're doing with my collaborators. We're trying to make a huge cohort of patients, and we're inviting our colleagues to include their patients in a prospective health database. We're planning to send an email to most of the bariatric surgeons who wants to participate to include their follow-up follow-up data beyond 5 years, to have a very heterogeneous cohort of patients from all over the world beyond 5 years, and try to duplicate our data. If this is true, then we should, have the same, more or less the same rate. But yes, we're going to increase the cohort of patients and working hard on this topic.
Exactly. Manuela, can we have the second poll, please? I think maybe we can see the results of that. Second question. Yes. I think the poll is open, and I would request the participants to put in their answers. We will close it in the next 5 seconds.
C'était quoi l'ensemble parce que j'ai pas eu le temps de lire la première question.
Okay, I think we can close it now. Okay, so about 29% of people say that the endoscopy should be done once a year. 43% believe it should be once every 2 years. 21% at the end of 5 years, and okay. So most people actually, I mean, about 40% people feel that once in 2 years should be okay, but we don't really have a consensus here. But that's fine, I think. Okay. So I would like to.
That 5 years actually. I don't think it's in France they trying to to say that patients should undergo endoscopy at 1, 3, and 5 years. I think this is too much. It's too. It is a big issue. I have a lot of patients undergoing sleep gastrectomy. So I think that 5 years is a nice follow-up time to identify patient with GERD, patient with
Yes.
Barrett, and
Yes.
patient who have nothing. And so
Right.
beyond 5 years, we'll have some patients will need further follow-up. Those will undergo conversion, and those
Yes.
will get out of follow-up, endoscopic follow-up.
All right. Okay. And I think there would also be an issue with the insurance and people paying for it as well. So too many endoscopies very frequently may be difficult to do. So, all right. So I think one of my last questions is going to be that from you people, that what do you think are the implications of these findings for practice for a common bariatric surgeon across the world?
This is for us. I think again, I mean, the main message of this paper is that a 5-year follow-up endoscopy may find. I mean, it's important in general practice, in bariatric practice, to identify patient with Barrett. So we can expect 20% of Barrett at 5 years. So endoscopy will find 1 patient in 5. So it's good. It's not 1 in 1 million. So it's good to do it. But again, we'll need to confirm this study in a larger cohort of patients. But still, as this is the third patient, the third study that finds the same results in terms of GERD and Barrett rate at 5 years, beyond 5 years, I think it's a reliable data. And I think the bariatric surgeon should think about doing a control endoscopy beyond 5 years.
Correct. And what is your thought about pre-operative endoscopy? Should we be doing it for everybody or only for symptomatic people?
Yeah, this is what in France. This is what is. We are anyway. All patients have to undergo an upper GI endoscopy before bariatric surgery. This is the recommendation of the Haute Autorité de Santé in France. So this is not a problem for us. We're not thinking about this. Then, as a surgeon, I would never operate on a stomach who has never been explored before. I think it's the same for colorectal surgeons. But I don't want to get into this issue. But still, in France, this is something that is done for all patients.
All right. Okay. Okay. Any closing remarks by you for everyone here?
We all want to thank you for the opportunity to share our paper and our results with you all. And this was a great pleasure and honor for us, me and for my junior surgeons who did the study with me. So have a nice day.
Thank you so much.
Thank you so much.
Really congratulations for such a good study and such an important one on that. So thank you for your time and for enlightening everyone. And I think the way to go forward would be to probably do these studies maybe in a much larger sample size with more and more centers involved. So I wish you all the best. Thank you so much.
Thank you very much. Thank you.
Thank you. Bye.
Thank you to all the delegates as well and for posting such interesting questions for all the doctors. Thanks a lot.